Now we're up to the teratology and maternal fetal infection section. The teratology stuff is pretty much all the same stuff that was talked about in step one. There isn't anything new that's teratogenic. So all the same teratogenic stuff that was discussed in step one is just going to be repeated here. So let me find it over here as well, actually. Teratogen. I believe there's a whole list here somewhere as well. And then if you actually ever do this, if you actually type teratogen from the beginning and just keep going all the way down, you would actually get to see all the different places where things are teratogenic. And as far as microbiology is concerned, a lot of those medications, a lot of those antibiotics are teratogenic, right? And then we just saw earlier the aminoglycoside. Here we're seeing how there was a difference between methimazole versus propylthiouracil, that you can't use them openly during pregnancy, right? So there was a whole concept of how you had to use PTU, propylthiouracil, in the first trimester because methimazole is very teratogenic, right? It can actually cause aplasia cutis and a bunch of other actually problems. But then in the second and third trimester, you're actually supposed to use methimazole and not PTU because PTU isn't teratogenic, but it can cause hepatotoxicity in the mom, which of course would be problems for the baby as well. Right? Let's see. We keep going. We have leflunomide. That one I haven't really ever seen a question on leflunomide being teratogenic medication. I guess it could be a problem if it's a question about a woman who's pregnant and she has rheumatoid arthritis or psoriatic arthritis and she's trying to treat it. Then of course leflunomide would not be something you could give to her. This is a rarely tested medication, but it's always those rarely tested things that are very high yield. Because this is a medication that reversibly inhibits dihydroorotate dehydrogenase, which is definitely a key medication for treating all kinds of things. Actually, many of those autoimmune conditions. Here they tell you that it prevents pre-immune synthesis, which suppresses T cell proliferation and can help with both those forms of arthritis. But definitely a teratogen, so don't give it to a pregnant woman. Moving on, there's of course lithium. Yep, this one is commonly tested. Right, patients taking lithium when they are pregnant. Lithium has a whole bunch of symptoms it can cause in the patient itself, and then of course it's also going to be teratogenic for the baby by possibly causing the same symptoms in them. So once you finally get into early fetal development in the step 1 book, you learn that weeks 3 to 8, which is the embryonic period of massive development, right? So in those early stages, most of the changes take place, and there's a lot of organogenesis and movement of different dermal cell layers and whatnot. So of course those weeks from 3 to 8 are when teratogens are going to be causing the most issues, right? So I have a little thing written here: 3 to 8 ogens, try 8 ogens, or teratogen. If you're having any trouble remembering that, but the point is just to remember that in the early embryonic period, that is when teratogens can cause the most damage. And then here we finally have that full list of all the things that are teratogenic and what they can possibly do, right? So now you should have a pretty good idea of this list. You should have most of it memorized. Definitely know the whole substance abuse part, know what alcohol, cocaine, and smoking can do. You should know about maternal diabetes, and then most of these teratogenic medications, you've probably already seen questions on the majority of them. But yeah, this is basically all the same stuff that's going to be discussed once again here as well. So they have this table, right? Common teratogenic agents and their associated effects. So ACE inhibitors can cause fetal renal tubular dysplasia and neonatal renal failure. So of course, a pregnant woman is not treated with ACE inhibitors if she's having any hypertension problems. In fact, as we go on, we're going to see that hypertension shouldn't really be a factor in pregnancy at all. Otherwise, that's very much indicative of problems that are going to lead to like preeclampsia and eclampsia, and both of which are really, really big red flag issues in a pregnant woman. Alcohol, so fetal alcohol syndrome, growth restriction before and after birth. mental retardation, midfacial hypoplasia, smooth philtrum, renal and cardiac defects. Consumption of more than 6 drinks per day is associated with a 40% risk of fetal alcohol syndrome, which causes an appearance of this type. Right? So you get the microcephaly, small palpebral fissures, mid-face hypoplasia, a smooth philtrum, so you don't have that indentation in the middle, and then a thin vermilion border. Right? This is actually, uh, you know, not the worst thing on earth because the child will be functional, minus whatever, of course, mental retardation might be there, but the child doesn't die. However, it is a really big mark to put on your child, right? Because anyone that sees that child, of course, none of us really knew these things when we were younger. When we were in school, we didn't know that this is what someone with fetal alcohol syndrome looks like. But it's still something that people can see and identify as abnormal, right? And then it's not a good thing. It's not a good look. So this is something you have to heavily advise against. And if you ever see a patient who is pregnant, has a history of being an alcoholic, but then maybe went through rehab or something, well, rehab isn't permanent, so you have to always consider that maybe they went back to it. Amphetamines will just cause preterm delivery or placental abruption, preeclampsia, intrauterine growth restriction, and fetal demise, which we looked at last time. That fetal demise was a death of the fetus after 20 weeks, right? Amphetamines are basically hypertensive, so they can cause vasoconstriction, which would, of course, decrease blood supply. Androgens, virilization of the female fetus, advanced genital development in male fetuses, most commonly caused by maternal luteomas, right? So luteal cancer, luteoma. This is not something people abuse. This just happens because the mother has some kind of issue that caused her to have more androgens than normal. Carbamazepine, which is the main treatment for trigeminal neuralgia, right? So this is another medication you cannot give to a pregnant woman. It can cause neural tube defects, which is already bad enough, but then of course there are other issues, including growth restrictions. So don't give carbamazepine to a pregnant woman. Now, when you see something like this, I forgot the name of the medication, but let me see: trigeminal neuralgia treatment in pregnancy. So when you see these things, you should always have an idea of what you're supposed to give a pregnant woman if you can't give these, the standard medication. Trigeminal neuralgia in pregnancy can be managed successfully by conventional radiofrequency ablation of the Gasserian ganglion, according to a case report published online June 2nd. Okay, so other than that, pregabalin, so something like gabapentin. Right, pregabalin would be the treatment in a pregnant woman. But again, like you have to know. So when you're seeing any medications, right? So coming back to step one book, for all these medications over here, these are medications you can't give to pregnant women. Then you need to figure out what can you give to a pregnant woman if you can't give one of these things, right? Like for hypertension, if you can't give an ACE inhibitor to a pregnant woman, what would you go with? And so on and so on. So all of these topics are discussed throughout the book in the step one topic. For example, if we go to hypertension in cardiovascular pharmacology, right? So then we can see that hypertension in pregnancy is managed with these medications, where the main one was labetalol, right? So hydralazine, labetalol, methyldopa, and nifedipine. So what medication you're going to use in pregnancy is something you need to make sure you have a good understanding of. Cocaine, again, very similar to amphetamine. This is also another vasoconstrictor, so it's going to cause growth restriction, and it can just cause many congenital malformations as well anywhere in the body, bowel atresia, and cerebral infarction in the baby. Diethylstilbestrol, this is just a terrible medication and a failure of medicine in the past, where this would cause clear cell adenocarcinoma of the vagina or cervix, vaginal adenosis, and abnormalities of cervix and uterus or testes. Can even cause possible infertility. This isn't exactly a teratogenic medication. I wouldn't say it's teratogenic. It's just something that was used in relation to pregnant women and is now not exactly a great medication. You never use diethylstilbestrol anymore for anything, really. Lead increases SAB rate and stillbirth. So again, another problematic thing. Lithium we looked at. This can cause all kinds of problems in the mother, and it can also cause problems in the fetus. Epstein anomaly. Methotrexate also increases SAB rate. Organic mercury, never really seen a question on this, so wouldn't really worry about it too much. Phenytoin, definitely a big high yield medication from psych. This causes fetal hydantoin syndrome, like this picture right here. Right? So you're seeing intrauterine growth restriction, mental retardation, microcephaly, dysmorphic craniofacial features, cardiac defects, and fingernail hyperplasia. Fetal hydantoin syndrome is the complication, as discussed in the question below, which we'll see soon. Right? So a lot of problems, as you can see. Radiation, never a great idea to do any radiation for a pregnant woman. You don't do radiation for the fetus as well, nor do you do radiation for a newborn until quite a long time after the development, because their bones and everything are still developing, and radiation is going to be pretty problematic, right? So don't do it. They tell you here that it can cause microcephaly, mental retardation. Medical diagnostic radiation that delivers a very weak radiation to the fetus has no teratogenic risk. However, that's still something you want to avoid. Streptomycin and kanamycin can cause hearing loss. They're actually really bad for the cranial nerve 8. Tetracycline, most commonly discussed medication. We know it can cause that yellow discoloration of the deciduous teeth, right? So just a teeth problem, right? So teeth tetracycline is in the name. Thalidomide, another failure of medication, right? So once again, this isn't necessarily, so actually compared to diethylstilbestrol, this is actually a teratogenic medication, right? Diethylstilbestrol is not really a teratogenic medication, doesn't really do anything to the baby, but it's bad for a pregnant mom in general. Thalidomide was made for pregnant moms to manage their morning sickness, and everyone that took thalidomide to manage their morning sickness ended up essentially killing their baby because it would cause bilateral limb deficiencies. So babies were born either without limbs or limbs that were in completely out of whack locations due to messing up the Hox genes and stuff like that. And that was a really big mistake. Trimethodione and paramethodione, again, more medications, never really seen them, but they can cause cleft lip and cleft palate, which is the general list of, so the symptoms that this causes is the general list of teratogenic effects anything can possibly cause. So this is probably why this is never tested. It doesn't cause anything special or unique. Valproate, very high yield medication, anti-epileptic. It just causes neurotube defects, mainly spina bifida. Definitely tested a lot. Vitamin A derivatives, you can't give vitamin A derivatives to pregnant women. The isotretinoin, right, that is used for acne management can be prescribed to a man, but cannot be prescribed to a woman unless you definitely do a pregnancy test and make sure that the woman is taking at least 2 forms of contraception. If the patient declines taking any form of contraception, you don't give them the isotretinoin, period. Doesn't matter, right? You can give them the topical form of tretinoin, that's okay, but not the oral pill, right? So the topical tretinoin actually does enough of a good job to manage acne, and it shouldn't be a big problem. But the isotretinoin that you would give them for oral intake is a no-no. That's not safe for them at all. And the last one here, warfarin. So warfarin wages a war on the fetus. It's actually going to cause nasal hyperplasia, stifled bone epilepsies, developmental delay, and then also these ophthalmologic abnormalities. So we don't really use warfarin that much, with normal individuals anyway. We're very careful with how we use warfarin in everyday patients as it is to begin with. So with pregnant patients, we definitely don't use warfarin. This was a huge discussion when we talked about heparin versus warfarin, and we talked about all the different concepts there and what's the better idea for pregnant women. And heparin was actually okay, but not warfarin. Warfarin is a no-no. Down here is an example of a question of how things look like when you get tested on these teratogenic things. So this question says, a newborn male infant is evaluated in the neonatal ICU for growth restriction. He was born to a 29-year-old woman, G3P0A2. So this is actually pretty unique, right? So G3, so she's been pregnant 3 times. That's 3 gravidities. doesn't have any live kids right now, and two abortions have occurred, right? Which can mean that either she got them done or she just had um, natural abortions because she's got some problem. So he was born to a 29-year-old woman who did not receive prenatal care. So did not receive prenatal care is pretty big as well. So we're talking about newborn male. She presented in labor at about 38 weeks gestation and had a forceps assisted vaginal delivery due to fetal heart rate abnormalities. Apgar scores were 6 and 8. Weight is 5.5 pounds. Physical exam shows microcephaly, a wide anterior fontanelle, cleft palate, and hypoplasia of distal phalanges. Further evaluation of the mom would most likely reveal a history of what? So just off of these list of symptoms, you have to figure out which teratogenic medication she must have been taking. That's all this question gave you, right? Um, so this baby looks like this, right, with really short fingers, hypoplasia of the nails and phalanges. So I always think of the phalanges for phenytoin, right? They both start with a PH. And that should be enough for you to get the answer and memorize it correctly. It can be from some other things as well. So they tell you here the infant most likely has fetal Haddon-Toyne syndrome, which occurs due to in utero exposure to an anti-epileptic. So generally speaking, you could have really picked any anti-epileptic and it would be okay. Phenytoin, carbamazepine, valproate. Multiple anti-epileptics have teratogenic effects due to their ability to cross the placenta, resulting in low folate levels and high oxidative metabolite in the fetus. Right, a lot of those anti-epileptics, when we looked at them in the neuro videos, we saw that they were actually requiring to give folate with them. Right, you should give folate with those medications, even to the patient themselves. My friend that I always talk about, where she used to be on valproate, then she was moved over to topiramate, and topiramate was much more better for her, and she lost weight. All of those things, right? I often tell you guys that she had two major issues when she was taking valproate. One, it was making her gain weight. Two, she was actually losing hair. But valproate doesn't have alopecia as a side effect. It's the folate deficiency that was making her lose hair. Right? So that's one of the key things to keep in mind. When she switched over from valproate to topiramate actually causes you to lose weight. It doesn't do anything to folate, and it was good for her migraine prophylaxis aspect as well. The likely combined effects result in the associated cleft lip and palate, wide anterior fontanelle, distal phalange hypoplasia, and cardiac anomalies. The associated neural tube defects and microcephaly can also result in developmental delay. Patients who require anti-epileptics during pregnancy should be titrated to the lowest dose for seizure control prior to conception and started on high dose 4 milligram folate supplementation also prior to conception, right when they're actually trying to get pregnant. One of the key things that a lot of parents either choose not to do or are unable to do because they're not covered insurance wise, or because they're illegal and they're afraid of going to a doctor, many scenarios, or because they're actually very illiterate and they feel like everything should be natural, right? So all kinds of people out there. But one of the key things is that when you are trying to get pregnant, right, when you've decided, family planning, you talk to your husband, you figure it out, and you're like, all right, let's do this, one of the main things that need to be done as part of doing this is to go see your OBGYN and have a discussion like, all right, we're getting ready to get pregnant. What should we be watching out for? What are some tests you might need to get done? Stuff like that. This patient decided not to come in for prenatal care at all. So, of course, there's going to be some kind of problem here. So main thing here, understanding the many symptoms of things. And then just based off of those symptoms, you have to pick what medication the patient might have been taking. Right, and then here we have congenital stuff. So now we're going to go to maternal fetal infections. Right, maternal fetal infections. So this is the whole list of your tortious pathogens right here, all of which are things that can just cross into the baby. Can occur at any time during pregnancy, labor, and delivery. Common sequelae include the following: premature delivery, CNS abnormalities, anemia, jaundice, hepatosplenomegaly, and growth restriction. A baby having hepatosplenomegaly is always a huge red flag. That's a big problem. The most common pathogens involved can be remembered through the use of the tortious mnemonic: toxoplasmosis. Other is just this list here: parvovirus, varicella, listeria, TB, malaria, and fungi. You do have to kind of know them. So the O part is the only part that's a bit of a list. But toxoplasmosis, rubella, CMV, HSV, HIV, and syphilis. And they all have things that they cause congenitally in kids, in infants. So definitely, something worth revisiting if you forgot about it, right? So you can always go back to the step one book, visit each one of these things in microbiology, and see what the whole presentation was of the baby. Also see what the whole presentation was of the patient, because you will often get questions where you might have a patient, maybe the patient has syphilis, they'll describe tabes dorsalis, right, which is part of tertiary syphilis, and then they'll ask you, she's pregnant, she just delivered a baby, what are some symptoms the baby's going to have? Well, first things first, you would have to actually identify that the mom had syphilis. They're not going to always tell you the mom has syphilis. They'll tell you symptoms that the mom has, and based off of that, you'll have to understand that the mom has syphilis. So symptomatology of each of these things in the mother has to be known, and then based off of that, you can predict what is going to cause in the baby as well. Pregnant women should not change a cat's litter box to prevent exposure to toxoplasmosis, which had huge things to do with the cat, as both the cat litter as well as just cat feces in general and food. Right? However, that can mix. I'm not sure how that can ever mix, but that's definitely a thing in questions. So right here, this is preventing neonatal group B strep infection. So this question must be about GBS. Let's take a look. 23-year-old woman, G2P1, at 37 weeks gestation, comes to the labor and delivery unit due to contractions and leakage of fluid for the last 8 hours. She had routine prenatal care until 20 weeks gestation, but has not had an appointment since moving across the country. Her prior pregnancy was a term vaginal delivery complicated by intraamniotic infection. Her infant spent 3 weeks in the neonatal ICU for early onset neonatal sepsis. Temperature, blood pressure, pulse are okay. She has grossly ruptured membranes with clear fluid in the cervix is 3 centimeters dilated and 30% effaced with the fetal vertex at the -1 station. This sentence might not have actually meant anything to you, but when you're done with obstetrics, you need to make sure this makes sense to you, that this should stand for something to you, right? That the cervix is 3 centimeters dilated, 30% effaced, and that the vertex is at the -1 station. Leukocyte count is 13K, hematocrit is 33%, and platelets are 189K. What is the indication for intrapartum GBS prophylaxis in her? Well, it's pretty obvious, the neonatal sepsis in prior pregnancy, right? Her neonatal sepsis that occurred in her prior pregnancy would definitely be a huge indication for intrapartum GBS prophylaxis. Anything that occurred in the prior pregnancy means a lot for the current pregnancy, because things can just happen again. 20% of people chose intraamniotic infection in prior pregnancy, but intraamniotic infection is a whole different thing. The table to the left was given. Streptococcus agalactiae, which is a common colonizer of the maternal GIT and genital tracts, is what causes this. Vertical transmission may occur during delivery or after rupture of membranes, leading to neonatal sepsis and pneumonia. Intraamniotic infection is typically polymicrobial and may involve GBS. However, most neonates of women with an intraamniotic infection do not develop infection or sepsis. Intrapartum penicillin is given, but for patients with a penicillin allergy, cefazolin is the most appropriate therapy. So this is the other reason I put this question here, because it was a pretty easy question, but clearly 50% of the people are the only ones that got it right, so 50% picked the wrong answer, even though it is honestly a pretty easy question. There wasn't even much to worry about in the question. That's all I highlighted was neonatal sepsis. Right? Her prior pregnancy was a term delivery complicated by intraamniotic infection. Her infant spent 3 weeks in the neonatal ICU for early onset neonatal sepsis. So her prior pregnancy had both the intraamniotic infection and neonatal sepsis. But they didn't talk much about the intraamniotic infection part. The neonatal sepsis part, they didn't need to talk much about, because that's already a huge deal, and I know about it, right? I know that neonatal sepsis in general is bad. Neonatal sepsis is really bad, right? And then that should make it clear what this question is about, right? But the other reason I put this question here is because of the cefazolin part, right? We always hear penicillin and ampicillin as the things to give intrapartum after week 35, right? Here they were after less than 37 weeks gestation, but we never really see the cephalosporin part. Even this table doesn't have it. It just says IV penicillin. So this explanation did a good job letting us know that cefazolin is the other medication you could pick for treating intrapartum GBS. That's a very critical little thing there. You could have a dumb question on that, and now you'll know the answer. And then here they have a long list of everything that is related to congenital infections. All right, so you just spend some time taking a look at it. Definitely go back to the step one book to revise it. Anything that you forgot, just make sure you refill and re-understand. There's not much to talk about for me over here. It's just pretty much just reading and revision from the step one book. One thing, just the notes I put here. So, like for example, HSV. Right, HSV is a huge issue. In America, it's pretty much safe to assume that if you're about to have sex with someone, it's very much likely they have HSV. So never have sex with someone new unless you've gotten both people tested. Both people should always get tested before having sex. Now that being said, a lot of people still don't get tested. So herpes is everywhere. It's very rampant, and it's not something you can eradicate. It stays dormant. So pretty much everyone has herpes, and it's really scary. Intrapartum transmission, if the mother has active lesions. Transplacental transmission is rare. So one of the key things here was this active lesions thing, right? If there are no active lesions, then you can just perform amniotomy and do vaginal delivery. Right, so very key thing to keep in mind. You have to pick this as an answer choice, not anything else. Right, there's going to be all kinds of answer choices with these questions. You got to be very careful. If the mother does have active lesions, then you have to start the mom on acyclovir and perform a C-section rather than doing the vaginal delivery. Right, because if you do the vaginal delivery in a mom who has active vaginal lesions, you know for sure the baby is going to get the HSV. So that's also something to watch out for. So it's so bad that not only does it stay in the mom, but then when the mom has sex with the dad got it too now, and then the mom can even pass it on to the newborn. If she doesn't get neonatal care, and if she doesn't get prenatal care and stuff like that, then this is something that can happen. In fact, truth of the matter is that if the mom has active lesions, depending on how high her HSV titer is, even this C-section poses quite a risk that she might still be giving it to the baby. It just lowers the risk doing a C-section rather than delivering by vagina. But really, really sad how much of a problem herpes is. HIV, very heavily tested, right? In utero, at delivery, or via breast milk. It's got so many ways it can be transmitted to the baby, right? So pregnant women who have HIV, even after they deliver, depending on their HIV cell count, they probably should not be breastfeeding at all. Don't breastfeed your mom. Don't breastfeed your child if you're a mom with HIV. But you can only advise your patients. You can't really control them. And then here's the syphilis stuff. So here's a question on syphilis. A newborn boy is brought to the nursery for evaluation. The mom received no prenatal care. So here we go again. Every time that happens, something's going to go wrong. But reports that the pregnancy was uncomplicated and she was healthy. Well, anyone can say that. A patient can come and tell you, I'm very healthy, I eat well, I'm doing just fine. Then you do their labs and you find out they have hyperlipidemia and blood pressure. So, this woman telling you she's healthy doesn't mean shit. The infant was born via spontaneous vaginal delivery and required no resuscitation. So, vaginal delivery, that's another thing you keep in mind. So, she tried doing a very natural kind of bullshit. Apgar scores were 8 and 9 at 1 and 5 minutes. On exam, he is below the 3rd percentile for weight. So, he's not growing well. Right, below the 3rd percentile for weight. 25th for length and 50th for head circumference. So length and head circumference are within appreciable ranges, right? Anything below the 15th percentile and anything above the 85th percentile is a red flag. Hepatosplenomegaly is present. Over the next 48 hours, he develops jaundice, clear rhinorrhea, and a maculopapular rash on the feet and buttocks that later desquamates. What congenital infection is most likely? So now we have to understand that the mom actually thinks she's healthy. So if you're picking an answer choice, you shouldn't be picking an answer choice that would never present a mom that thought she was healthy, right? You need to pick an answer choice of some kind of infection that the mom must have had, but it was asymptomatic, right? That it was causing symptoms that she couldn't really notice were taking place. And the answer to pick was syphilis, right? Not CMV. 25% of people chose CMV. But CMV is not asymptomatic. Right? That actually causes a lot of problems. And congenital CMV presents in a very unique manner, not with rhinorrhea and a maculopapular rash. So there's two ways of answering these questions every single time, right? All of these congenital infection things, what did the mom present with? And what are the symptoms the baby presented with? And the combination of these two things is what's going to help you figure out which answer choice to pick. So at least that's nice. You're not relying on just one thing to get the right answer. The profuse rhinorrhea and desquamating rash suggest congenital syphilis. Prenatal diagnosis and penicillin treatment can prevent this. Now here, this is another case scenario where penicillin is supposed to be used. The other option was tetracycline, which you cannot give to a pregnant woman. So if you're a pregnant woman and you need to be given penicillin for syphilis, you still give penicillin for syphilis, even if you're allergic to penicillin, right? And that's the point I was trying to make. If you can't give penicillin, you still have to give penicillin. You desensitize them as much as you can, even if they're allergic to penicillin, because you definitely can't give the tetracycline. That's teratogenic, right? Penicillin therapy is curative and prevents development of late manifestations. Congenital CMV would have periventricular calcifications, among other things. I think that's right here. Yeah, CMV, right? Primarily transplacental. Petechial rash and periventricular calcifications are the two main symptoms. There are others, and all you really need to do is give postpartum ganciclovir, and the baby should be okay. CMV is not as bad as most of these other ones, but it's better to treat all of these things in the mom before the baby is born, right? So syphilis has a whole list of symptoms, which makes this easy. The more symptoms, the easier it makes it, because then there's more things for you to look for. And again, pretty easy question in that aspect. There's a table of things here. So these two tables are extra things that are not in the book per se, or at least they're not on this page, right? So perinatal hepatitis B infection and congenital Zika. So when Zika was actually quite rampant, all the airports had signs up for Zika virus and like symptoms to watch out for. And then if you're having any of these symptoms and you're pregnant, you should come to a staff member ASAP so we could check you, stuff like that. So let's take a look at this. HBV. HBV can be transmitted vertically from infected pregnant women to their infants. About 90% of infants with vertical HBV progress to chronic HBV, which can of course lead to cirrhosis, hepatocellular carcinoma, and liver failure. Newborns of all moms with active hepatitis B virus should be passively immunized at birth with Hep B IG, followed by active immunization with recombinant HBV vaccine. These should be given within 12 hours of birth, regardless of the infant's birth weight or clinical condition. All right, so prevention is very critical. You need to do both things. HBV vaccine, which is the active immunization, and hepatitis B IG, which is the passive immunization, where you're actually giving pre-made antibodies, right? That's passive. Active immunization is when you make the baby make its own antibodies with the vaccine. So you need to do both things. And then with Zika, congenital Zika syndrome causes severe microcephaly. Kids have thin cerebral cortices with multiple intracranial calcifications due to tissue necrosis and a closed anterior fontanelle. Right, so now the intracranial calcification thing is actually a symptom that's shared by many things. If you come back to toxo also has intracranial calcifications, right? Congenital toxoplasmosis. CMV has periventricular calcifications. And then right now we're looking at Zika, which would also have it. So where the calcification is occurring inside the brain is what you need to watch out for. Because a periventricular calcification can also be referred to as an intracranial calcification that's just near the ventricles, right? So you have to be careful. The question may word it as just an intracranial calcification, and then maybe they give you like a radiograph, CT or something, and then you look at where the calcifications are, it's right next to the ventricles, then that's CMV. That's about it for that. Let me see now. Okay, so now next thing here is spontaneous abortion. So before we move on, very important just to revise, make sure you go back to the step 1 book and take a look at each one of these guys individually in the microbiology chapter, right? Just to have a good revision of what it causes in the mom, what it causes in adults in general, and what it will cause in the baby. Keep in mind for syphilis, pretty high yield question, that syphilis was part of the CARS mnemonic, C-A-R-S, right? Where the S stands for syphilis. This is Coxsackie, A, Rickettsia, syphilis. These are the guys that cause a rash in the palms and soles, right? These are the only guys that cause palm and sole rashes. So if they give you a patient who has a rash in the palm or sole, and then they're about to give birth to a baby, it's an immediate indication. You just put them on penicillin. Just give them penicillin right away because it's most likely syphilis. And depending on how soon they're delivering, if there's a lot of time before delivery, then maybe you can have time to actually test for syphilis. But if they're delivering very soon, give them penicillin right away. Start the penicillin ASAP. So spontaneous abortion, the loss of products of conception before the 20th week of pregnancy. Right, so we talked about this 20-week border being a big thing, right? Last time we talked about how after 20 weeks is what's considered fetal demise, if something happens to the fetus and it dies. There's many reasons it can occur. Risk factors are as follows: chromosomal abnormalities, maternal factors like an inherited thermophilia, immunologic issues, anatomic issues, genetics, other environmental factors like things that the mom does that she shouldn't be doing, fetal factors like an anatomic malformation in the fetus, recurrent SAB, 2 or more consecutive SABs or 3 SABs in 1 year, right? So that's always going to be a big issue. And then the main thing here is going to be that most of these women who do get a spontaneous abortion, you can see from this list of things that all of these are things you could catch if the woman is coming in for her prenatal and perinatal checkups, right? If you're keeping up with your chronic, with your scheduled doctor visits, then all of these are things that the doctor can check and know about and manage. If you're not coming in, then no one's going to know what's happening, and then of course it's going to be a really big problem, right? So let's take a look at what you're supposed to do. So history, see table 2.11 for the types of SABs. Right, types of spontaneous abortions, that's what SAB stands for. And then how you're supposed to diagnose it and how you're supposed to treat it. That's going to be the key thing for us. So diagnosis, clinical presentation, and physical exam. Non-viable pregnancy is going to be a gestational sac that's more than 25 millimeters without a fetal pore or absence of a fetal cardiac activity when CRL is more than 7 on transvaginal ultrasonography. These are both scenarios that are really indicative of the fact that this baby is not going to be born and you need to do an abortion ASAP, because if you don't, then there's a risk of DIC. Best initial test is just, of course, ultrasound. Don't pick X-ray, MRI. These are not things you do because they're going to affect the baby. Not good for the baby at all. But the ultrasounds don't really do anything to a baby. Ultrasonography can identify gestational sacs, fetal pole, and fetal cardiac activity, which are the 3 things you care about, as we just saw. Right, if the gestational sac is big, but there's no fetal pole, that's really bad. And if the cardiac activity is not good, then that's also really bad. Right? Next best test is to check for beta ACG, because a good pregnancy will have a good amount of beta ACG. If beta ACG is low and the mother is supposed to be really pregnant, then it's not working out. And then treatment depends on what's actually causing the problem, right? So of course, whichever one of these things is the key problem, you have to treat that aspect of the issue. So here they have complete, threatened, incomplete, inevitable, missed, and septic, and then intrauterine fetal demise. Right? Those are your long list of different types of abortions. And then this is an image from UWorld showing you the abortion types visually. Right? So let's take a look at each one. The first one, complete abortion. Right? Complete abortion. Bleeding and cramping has stopped. POC expulsion. Diagnosis is by closed os, and ultrasonography shows no POC. So let me just check something real quick. Okay. Right. So if you don't see any POC, and remember POC stood for products of conception. So if you don't see the products of conception, which is basically that little fetus, the tiny thing that's developing into a baby, if you don't see any of it, or if it's been exposed, right, if it came out, so like right here, this is complete, right? You can see there's going to be some vaginal bleeding, a closed cervical os, and then the products of conception are completely expelled. So it has been aborted, right? There's nothing to do here. The only thing you do need to do is to make sure that all of it was aborted, because if anything was left inside, that can lead to DIC. Threatened. So threatened is uterine bleeding, is going to present with uterine bleeding plus or minus abdominal pain, no POC expulsion. Right? No POC expulsion. So if you look at it, it's right here. There's the middle one, threatened vaginal bleeding, a closed cervical os, and fetal cardiac activity is there. right? There's a closed os plus intact membranes plus fetal cardiac motion on ultrasonography, which are all good things. Those are good things. What do you need to do? Pelvic rest for 24 to 48 hours and follow up ultrasonography to assess viability of the fetus. Right, so you really just put the patient on bed rest and really make sure everything is as perfect as possible. And by everything, I mean like literally everything from head to toe: electrolytes, blood pressure, all the medications they're supposed to be on, any um, changes in heart rate, anything that the mother is bothered by needs to be managed, and everything should be as perfect as possible because this is a threatened abortion that's possibly going to occur. And if anything's out of whack, if blood pressure is high, her electrolytes are abnormal, she has constipation, any of these weird things that can occur. There's a whole list of things that can occur to you from your head to toe. Anything is wrong, that can lead to the abortion actually going through. The threat will become a reality. Right? So you need to manage very aggressively. Incomplete. So this is a partial POC expulsion with bleeding and mild cramping. You will see visible tissue on exam. Right? So incomplete. So incomplete is the opposite of complete, right? So of course both these two guys are the ones that have expulsion. These do not have expulsion, right? These two guys have some expulsion. The complete, the whole thing is expelled. The incomplete one, some parts are expelled. You can see that one of the key things in this drawing is that the cervical os is really open, very, very dilated, right? So dilated cervical os, vaginal bleeding is occurring. Some products of conception are expelled and some remain. Either way, once you lose some products of conception, it's a dead baby, right? So that all you can do is really just get the rest of it out, right? So key thing here being the open os, very, very critical thing to watch out for. Manual uterine aspiration if less than 12 weeks, or do a DNC. Both of these are ways basically you're cleaning up the rest of the uterus, making sure everything else is out, because if you leave anything, DIC will come, right? You may also use misoprostol or expectant management in an inevitable and missed SAB. Right? So you just get everything out. That's it. There's no point in trying anything. You're not going to save the pregnancy. Inevitable, which also means you're not going to save the pregnancy. This is going to present with uterine bleeding, no POC expulsion. You're going to have an open os, plus or minus rupture of membranes. POC will be present on ultrasonography. However, let me see if there's nothing red there. Okay, perfect. However, this is again going to be a case scenario where the pregnancy will not go through, right? So vaginal bleeding, dilated cervical os, products of conception may be seen or felt at or above the cervical os, just like in this picture. Okay. So the two guys with the really dilated os are the inevitable and incomplete. Both of them start with IN, in. Okay, but the incomplete is like complete in the sense that something has come out already. Inevitable, it hasn't come out yet, but you know for sure it will. It's inevitable. It will come out. Right? The baby's gonna fall out. Missed abortion. So a missed abortion is asymptomatic with some cramping, no bleeding. So it's missed because it's asymptomatic. It occurred, but no one noticed it occurred. Right? So that's why you should be able to easily pick that in a question, because you'll see that the symptoms, there should be no symptoms that you would actually catch. Otherwise, it wouldn't be a missed abortion. If your question is about a missed abortion, you need to understand that whatever is happening was behind the scenes, nothing visible. So no bleeding, no symptoms, a little bit of cramping, which is normal in pregnancy anyway. Even the cervical os is closed. No fetal cardiac activity. POC is present on ultrasonography. But the no fetal cardiac activity basically means it's a dead fetus. You need to get it out immediately. If you leave it in there, then DIC will occur. Septic abortion. Septic abortion is not really one of these types. It's just sepsis that caused abortion. Foul smelling discharge, abdominal pain, fever, and cervical motion tenderness, plus or minus POC expulsion. Maternal mortality is 10 to 15%. Even the mom can die from this, right? You need to do DNC or manual uterine aspiration and get the baby out and just get the fetus out because it's dead, and start IV antibiotics ASAP, right? Because now at this point with the septic abortion, the main thing is to save the mom because the baby's already dead. And then intrauterine fetal demise, absence of fetal cardiac activity after 20 weeks gestation. Uterus is going to be small for gestational age. No fetal heart tones or movement on ultrasound. If it's been less than 24 weeks, you just do a DNE and get it all out. If it's been more than 24 weeks, then you induce labor within 1 to 2 weeks based on patient's preference. Right? Do not perform C-section even for a breech presentation. Offer autopsy to attempt to determine cause of death. But oftentimes patients don't want to know. But when patients say they don't want to know, you need to tell them that it's probably a good idea to figure out why this fetus died, because we need to know everything we can to prevent the same thing from occurring in the next pregnancy. Right? So after the mother is over her little emotional period of being, of course, traumatized, right? This is really sad when intrauterine fetal demise occurs, because intrauterine fetal demise is much more sad than fetal death, right? Because fetal death is early, so you've only been carrying the baby for maybe a few weeks, but you've been carrying the baby for more than 20 weeks in intrauterine fetal demise. So now you actually have a very strong emotional bond with that baby. And when the baby dies after 20 weeks, that's really traumatic for moms. So moms don't really want to do an autopsy of that baby. But you need to tell them that it's very important to do it just so we know what happened, because we don't want it to happen again in the next pregnancy. Right? And that logic clicks with most parents very well, and they'll be like, yeah, you're right. Let's make sure we know what happened. Right? So that's going to be like an ethics question that you might get that you have to come up with. And then this answer choice, do not pick it, right? So they tell you, do not perform C-section. Right? It's a dead baby. Why are you wasting time doing the surgery to take out a dead baby, even if it has breech presentation? And your question will tell you it has breech presentation, which will be there really to just, push you towards picking C-section. Don't do it. Just induce labor, do the vaginal delivery, get the dead fetus out, and take care of the mom. Right? So intrauterine fetal demise. Management, dilation, and evacuation, which is what D and E stands for. Vaginal delivery, period. Just vaginal delivery, not a C-section. Very, very important thing to keep in mind there, because for sure it's going to be an answer choice. Right? Here we have a question. 29-year-old woman comes to the emergency department due to fever, chills, and lower abdominal pain. 2 days ago, she underwent D&C for a 9-week missed abortion. Then she initially had light spotting, but the bleeding has become increasingly heavy and malodorous within the last few hours. So heavy and malodorous. The malodorous part will often make you think of only one thing, right? Foul smelling. So it's going to be some kind of infection, maybe. She has also had increasing abdominal pain and a fever, which further tells you, even her initial presentation, fever and chills, there's some kind of infection. Fever unrelieved by acetaminophen. She has no chronic medical conditions, never had any surgeries, temperature is high, right? Blood pressure is very low, pulse is high, so she's definitely not doing well. On speculum exam, the cervix is visibly 1 centimeter dilated and has purulent discharge at the os. The uterus is enlarged and has cervical motion tenderness. Transvaginal ultrasound shows a thickened endometrial stripe. Urine pregnancy test is positive. She is started on broad-spectrum IV antibiotics and undergoes a suction D&C. She is at increased risk for what condition? So this question was actually doing a great job just teaching you one thing, that when you do a suction D&C, all kinds of things can occur. Here the correct answer was development of intrauterine synechia, which are intrauterine adhesions. Table above was given, which, where I put that table? Oh, intrauterine adhesions, this one right here. Okay, so we'll come back to that table right now. They go on to say she has septic abortion, a polymicrobial intrauterine infection. Suction D&C removes the infected retained products of conception. Her previous D&C for a missed abortion left some products of conception. She wasn't completely cleared. More aggressive suction D&C will denude the endometrial basalis layer, leading to possible Asherman syndrome due to inflammation, which is the intrauterine adhesions that occur. So basically, in all of these case scenarios where you needed to get the baby out, which are the first three, right? You need to get this products of conception, is what they call it, get the POCs out. Right? So if you need to get the POCs out, you need to do a great job getting the POCs out. And it's a very difficult thing to do, because if you leave anything, part of the placenta, tiny part of this, like maybe tiny part right there broke off and got left inside, anything left gets behind, boom, that leads to DIC. And if it was a septic abortion, that's going to be the one that has the infection, the fever, the foul, smelly discharge. Then there you really need to do a more aggressive cleaning, because this one can actually kill the mom. See, DIC is also practically fatal, but it's manageable and definitely avoidable. But this one, it's something that can be missed, and the mother can die pretty quickly. Right? So you go ahead and do the more aggressive suction DNC. And development of intrauterine synechiae is what she had, which is why she has a positive pregnancy test still. This is very rare. It doesn't really occur that much because we don't send a patient home until we've seen that the beta HCG levels have fallen and everything's clear and the patient is stable. Right? So we don't release patients. But here, apparently, she was released even though she wasn't completely back to normal yet. Right? Coming back to the top, there were some more questions regarding. Okay, so this one is an HSV infection question. This one is the abortion question. Let's do the abortion one. 37-year-old woman, G2P1 at 8 weeks gestation, comes to the office for a follow-up visit. Earlier in the pregnancy, she had nausea and breast tenderness that resolved several days ago, which are normal symptoms in pregnancy, so nothing to worry about right there. She has no other concerns. At her initial prenatal visit a week ago, ultrasound revealed an intrauterine gestational sac with a yolk sac but no fetal pole. Well, a week ago, yeah, so that's in the period, right? So we just saw that, where do we see, right here. So that 5-6 week, right, everything from 5 to 7, that is the time where you're supposed to have a fetal pole. So no fetal pole a week ago, and she's at 8 weeks now, so that means at week 7 there was no fetal pole. That's bad, right? Beta HCG level at that visit was 27,325. She's taking a prenatal vitamin, doesn't smoke, drink, or use drugs. Blood pressure is a little high. This is actually concerning for a pregnancy. Pelvic exam reveals a normal-sized retroverted uterus with no cervical motion or adnexotenderness. A transvaginal ultrasound is repeated and is unchanged from the prior visit. So that means even today, there's no fetal pole. Beta HCG is still high. What is the most likely diagnosis? Missed abortion. 40% of people chose hydatidiform mole, which doesn't make sense. Why would you think it's a mole? Molar pregnancy doesn't. Alright, so we'll see the explanation. 10% of people chose normal pregnancy, which definitely doesn't make sense, right? There's no way it's normal pregnancy if during this organogenesis phase there's no fetal pole, right? So that answer choice was completely irrelevant. She has a missed abortion, an intrauterine pregnancy demise at less than 20 weeks gestation, prior to expulsion, or products of conception. Patients may be asymptomatic or have decreased pregnancy symptoms. So basically, the fetus is dead, and there just hasn't been any expulsion yet. Physical exam reveals a closed cervix. Risk factors for a spontaneous abortion include advanced maternal age, which she is above 35. So remember, medically speaking, over age 35 is advanced maternal age. Due to its associated increased risk of fetal chromosomal abnormalities, ultrasound findings in a missed abortion include an embryo without a cardiac activity or an empty gestational sac without a fetal pole. Some early pregnancies can present without a fetal pole. Viability is determined with repeat ultrasounds and serial beta HCG levels. Repeat ultrasounds of a viable pregnancy reveal continued embryonic development. Serial beta HCG levels normally increase until the end of the first trimester. A decreasing beta HCG level indicates a demise and excludes a normal pregnancy. So let me see, what was hers? Yeah, hers decreased, right? Hers was 27,000, came down to 25,000. Right, so these are definitely not signs of a normal pregnancy. A hydatidiform mole presents with heavy bleeding, a snowstorm appearance on ultrasound, and an extremely excessively high beta HCG level. These are key forms or key clinical presentation of hydatidiform. The word hydatidiform has high to remind you that HCG is going to be extremely high, and ultrasound always shows this iconic snowstorm appearance. They didn't see a snowstorm appearance. Like ultrasound would give away. Ultrasound would literally give away the fact that this is a hydatidiform pregnancy. So they didn't describe that. So I'm not sure why 40% of people picked that. That's basically it for this question, right? So just a missed abortion, which is this first one, right? Where remember the patient has no symptoms that will tell you that she has an abortion, right? That's why it's missed. Last thing here, management of HSV, very high yield topic. There's a lot of questions in New World about this. 36-year-old woman, G3P2, so she's had 2 prior pregnancies. At 38 weeks gestation, comes to the emergency department due to regular painful contractions. The contractions began an hour ago, immediately after the patient had a gush of fluid Okay, so she has had no vaginal bleeding and fetal movement has been normal. Her last prenatal visit was 6 weeks ago. She has no known medical conditions and doesn't use alcohol, tobacco, or drugs. Vitals are normal. Fetal heart rate tracing shows a baseline of 140 with multiple accelerations and no decelerations, so that's all fine. Contractions occur every 2 minutes on the tocodynamometer. Fetal exam shows a cluster of clear vesicles. Boom, right there already. Sorry, not fetal. Pelvic exam. Pelvic exam shows a cluster of clear vesicles. Right, so a vesicular, that's basically a vesicular rash in the mom. So she has active lesions, right, with an erythematous base on the right labium minus. Speculum exam shows a pool of clear fluid in the posterior vagina. The cervix is 6 centimeters dilated and 100% effaced with the fetal head at the 0 station. She is very much ready to deliver. What is the best next step? Don't do vaginal delivery. Right? Even though everything is going perfectly fine for vaginal delivery, you do not do it. You perform a cesarean delivery. 70% of people picked it. 15% of people chose start antiviral therapy, which would still indicate that after starting antiviral therapy, you're going to do vaginal delivery. That would be the wrong answer choice, right? Diagram below is given. So, does the patient have prior HSV infection? No, then everything's good. Patient has prior HSV infection, then you need to start them with antiviral suppression at 36 weeks. And then, does the patient have lesions during labor? If the patient has lesions during labor, you need to do cesarean delivery. Right? If you started the antiviral suppression and the patient does not have lesions during labor, then you just do vaginal delivery. So the only times you could do vaginal delivery is when there's no signs of HSV. When you have signs of HSV, you need to take the baby out with cesarean delivery. And that's all this question is about. Very straightforward concept. Should not be something you mess up. Now, you're going to get a very complicated looking question, but the point is, if you see active lesions, you do not do vaginal delivery. Period. That's it. All right. So we're done with all of that. In our next video, we'll continue on into elective termination of pregnancy.